Welcome to this presentation, providing education and support to rural district clinicians in the Eastern Cape, South Africa, adapting to Covid-19. I am Dr. Alexandra Shields and part of the BAMSI team. The other members of the team include Professor Andy Parrish, Dr. DavidStead and Dr. Jenny Nash. We are very grateful for the opportunity to be presenting at this wonderful conference, alongside lots of other brilliant speakers and webinars. Buffalo City and AmatholeDistrict Medical Support Initiative, known as BAMSI, was set up in 2019. BAMSI aims to improve the quality of care in the Eastern Cape through medical education and support of the district clinicians by the consultants at the regional referral hospitals. To put it into context, the district hospitals are up to 180 kilometres away. Because of this, the clinicians working in the district hospitals can often feel unsupported, which may ultimately have a negative impact on patient care. BAMSI has always focused on teaching and quality improvement. When it began, it was run as a three-pronged strategy. It had an in-reach component where clinicians from the district hospitals came to learn as part of a week-long intensive training scheme. There was also the outreach part where the consultants would go to the district hospitals to provide teaching and support, and the resource development. This aimed to provide resources for the district clinicians, mainly based on quality improvement. Due to the COVID-19 pandemic, the in-reach and the outreach programs were paused. The team quickly realised that the requirement to teach and support clinicians did not stop because of the pandemic. In fact, it grew more necessary. And despite increasing working pressures due to the pandemic, the BAMSI team worked together to adapt to support and educate clinicians in the district hospitals. This process was challenging and involved many adaptations along the way. An overview of the methods used. We developed teaching sessions held on the video platform Zoom, which were consultant-led and interactive, and we were granted CPD accreditation for the sessions. Each session is reviewed to ensure accuracy and relevance. We decided on suitable times for the sessions and maintained these each week for continuity. The team reviews each of the sessions to identify any improvements, and we regularly encourage feedback. With these, we adjust the content and delivery of the sessions to ensure they remain relevant to clinicians. Clinicians can suggest topics and cases for discussion via the Vula app. This slide shows a little bit more detail about how we initiated the online teaching sessions. So firstly, we identified the key focus topics that we wanted to start the teaching with. So we had a syllabus for district clinician teaching. This was reviewed by the BAMSI team to check that it still remained relevant in the current climate. Then surveys were sent to the district hospital clinicians asking which topics they would like to be taught, specifically which topics did they feel they lacked confidence or knowledge in. From this, a list of key topics was generated, and this is where the online teaching sessions began. The BAMSI team had not delivered regular teaching in this way before, so had to learn how best this may be delivered. The team researched several different options, including different online video formats, and worked out which would be the best to start off with, including which was the most cost-effective and which provided the clinicians with the best delivery experience. We had to ensure that the files were in a format and size that could be accessible for people using data in a district environment. We had a few practice runs and recorded and reviewed the session to see what worked best. We then made the decision to use Zoom and use the live PowerPoint presentation features. Alongside the trials of the teaching sessions, Once we had determined the best time to hold the sessions as per the survey of the district clinicians, we then trialled these sessions too. We trialled a couple of different times throughout the week and then settled on Tuesdays as the best time to conduct the sessions. We then asked for feedback from the clinicians to continuously assess suitability. We also note when usual attendees or hospital groups cannot attend and ask specifically then for feedback of why they cannot attend and if there is any way we can support them attending in the future. As you can see from this slide, we have covered several topics so far, with a different topic every week during the teaching. We want to ensure the teaching is relevant to district clinicians, so have predominantly focused on general medicine and urgent care. This has included common investigations and procedures, which has been very popular. The district clinicians requested these topics and we were unsure initially if they would work over a PowerPoint and Zoom format. However, the feedback we have received has been really good. As a core value to the BAMSI team, audit is very important, and so we have included audit in clinical care and will continue to interweave this theme throughout the future topics. This is a flowchart of the process of delivering a teaching session each week. So firstly, a topic is chosen, then the topic is made into a presentation by the consultant. The presentation is then reviewed by the BAMSI team for relevance and accuracy. A Zoom link is then sent to the clinicians. The clinicians must then register for the teaching session. The teaching session is then delivered and it is recorded as well. And at the end and throughout this process, feedback is always encouraged. This is the process we use for delivering teaching recordings to the clinicians. So the recording is rewatched by the BAMSI team. It is again checked for accuracy and relevance to ensure that it is appropriate for teaching in a rural setting. The recording is edited to make it suitable for sharing. This means that it is a suitable size and format. The video is then uploaded onto YouTube and the YouTube link is shared with the clinicians. Again, feedback is encouraged throughout. The clinicians will get the teaching recording approximately 48 hours after the original live session. As you have gathered so far through this presentation, feedback is very important to us as we want to ensure that the teaching is relevant and suitable to the audience. There are many stages where we review the content and informally and formally gain feedback. Firstly, the team review every session, as already discussed in the previous slides. The topics are suggested by clinicians to the BAMSI team directly or via the app Vula. And as mentioned in previous slides, the teaching attendance numbers are monitored to see if we can support them attending future sessions. Clinicians are not formally tested on their knowledge on the topic areas. However, interaction via the discussions and then ongoing clinical performance, including initiating of audit projects, is monitored and used as informal feedback. A minimum of 2 clinicians are required to check each presentation using the criteria on the slide. This criteria has been adapted from the McMaster Optimal Ageing Portal web resource rating tool. As well as this, drug doses and recommendations are checked as per the Essential Medicines list, the adult version. So, how are we getting on? The sessions started on the 22nd of April 2021 as weekly sessions, and they are ongoing with new clinicians attending each session. 107 clinicians from 20 hospitals have attended the 19 teaching sessions. The majority of clinicians use mobile phones to attend the teaching sessions, with almost 70%. 15% use a laptop, and another 15% share devices. As part of the clinicians sharing devices, there are 2 groups of clinicians which are meeting each week to participate in teaching, and these are groups in Butterworth Hospital and Fort Beaufort Hospitals. Meeting as a group allows for discussion on the topic. This slide shows the clinician attendance by their location. As you can see, the clinicians where they meet as a group to attend the teaching has got the highest attendance numbers. We have noted a small number of clinicians have attended the sessions from other districts and other provinces. Because of this, we have had to include a disclaimer with the teaching to inform the clinicians that the teaching and guidelines are only relevant to the intended audience. Several lessons have been learnt through the process of delivering this teaching. Firstly, it is a huge team effort. There are several roles which must be undertaken, including a link with the clinicians, a presenter, a Zoom host, keeping registers and editing videos, etc. Timings of the sessions are key. The presenters and the clinicians must be able to attend the teaching sessions or have access to the video recordings. We have found that momentum is important, so we have kept at a regular time each week to ensure the clinicians know when the teaching will be and when they should expect the link for the teaching. We want the teaching to be relevant and interesting to the clinicians, so we ensure that the topics are ones they are interested in and would like to be taught. We believe feedback is very important, so we ensure there are many methods that the clinicians can use to provide feedback. We also value the clinicians giving up their time to be taught by us, so we have got CPD accreditation for this. As a way of ensuring that the teaching is relevant for the clinicians, we've realised how important it is to keep an accurate register of who is attending the teaching sessions, what hospital they work at, and if there are any trends in attendance, if there is anything that we can help or support the clinicians with in their attendance. We also know that there are certain elements which must be present in each teaching session. This includes references and guidelines and contact details of the presenting team. Finally, it was clear from the survey of the devices used to attend teaching that teaching sessions should be accessible via a mobile phone, as this is the most common way in which people attend teaching. The future plans for the team include development of a website to share the education resources. Also, involvement of more specialties to expand the current teaching curriculum. We also hope to provide data for clinicians to ensure they are able to attend the teaching session and are currently in the process of surveying the clinicians of what network works best in their areas. We also will continue to reflect and improve sessions based on feedback received. To conclude, district clinicians can feel unsupported, especially during times of increased pressure, such as the Covid-19 pandemic. Consultant-led education and support for the clinicians working in rural South Africa can be adapted to challenging working environments. It does not need to be stopped altogether. Support for district clinicians must be continued during disruptions such as the Covid-19 pandemic, and interactive video teaching is feasible and effective to do this. Once a format is established, the topics can be easily adapted depending on the audience and their weaknesses. Online teaching can reach a wider audience without the need for clinicians to travel or take time out of work to attend teaching. And teaching sessions can be developed into resources which can be shared or revisited. On behalf of the BAMSI team, thank you very much for listening, and I hope you enjoy the rest of the conference.